ASCO has accepted my results of a Bayesian randomization trial comparing proton versus IMRT for non-small cell lung cancer. I got an oral presentation, so that's why I came. Of course, I came to ASCO anyway for other meetings.
And can you tell us about the comparison between proton and, for example, a scattered therapy?
The comparison group are two. One is what we can consider standard of care, which is intensity-modulated radiation therapy given concurrently with chemotherapy. The comparison or investigation arm is the proton therapy. In this case, we used a 3D conformal passive scattered proton for comparison. That was the technology available at the time of the trial design.
Okay, and what kind of results do you find from the trial?
The results actually showed that using 3D conformal proton therapy in terms of the endpoint of the trial, which is radiation pneumonitis, the original thought is that the proton will be able to reduce the lung volume irradiated through the treatment and reduce the pneumonitis. However, given the technology delivering proton is 3D conformal, not intensity modulated, we found out actually the 3D conformal proton therapy irradiated higher volume of the lung with higher dose compared to IMRT. Therefore, actually the pneumonitis rate was slightly higher than we have expected. On the other hand, the IMRT technology has also been improving significantly. So the pneumonitis rate actually was nearly 50% less than we expected. So that's why that's kind of a little bit surprising to us, but the most important finding I thought is very encouraging from this trial is that both IMRT and proton are very effective in cancer control. The local failure of the patient at 12 months is only 10% or 11% compared to 25% in the past when we designed the trial. So they are both very powerful treatment options. Also we found is that in this trial what we did is we developed a pair of plans before we start treatment, and we chose only those patients with the two plans comparable or both acceptable in our standard of practice, and then randomize them. In this case, there's no difference. And then when patient had the plans not randomizable, meaning that one treatment plan is better than the other one, then we treated them with the better plan, and we also didn't find any difference. That kind of suggests to us that using pre-treatment plan evaluation is a very, very good way to select the patient for either IMRT or proton.
Can you tell us about the categories that you're using for the pre-select?
For patient eligibility, we included the patient with stage 2 to 3B non-small cell lung cancer. We also included the patient who had brain metastasis stage 4 and the patients who actually had a surgery in the past and then tumor recurred. So those are very unfavorable patients in terms of survival. But in our study, actually both proton and IMRT arm together, the median survival time is 28.8 months, which actually is identical with the best practice right now published by RTOG 617. In that study, the median survival time is 28.7 months. But that study included only untreated patients, stage 2 to 3. We included heavily previously treated with the chemotherapy patient, progressed on the chemotherapy, also patient with the stage 4 and recurrent disease. Therefore, the survival outcome of this study, either with the proton or IMRT, is really pretty encouraging.
You mentioned a difference in effective dose. Were there any reports of toxicities or anything in the patient reports that might favor one or the other?
Right now, as I mentioned, the endpoint we used is pneumonitis. In this category, we have not seen a difference. Basically, there's no difference between those two arms. However, the heart exposure was much, much lower in proton therapy arm, which we believe will probably translate into survival benefit. Actually, we have a translational study and a correlative study going on, looking at the cardiac troponin, which is a marker when patient has ischemic change, they release to the blood. We found out that actually, in the proton arm, the troponin elevation is much less compared to IMRT. Of course, those are ongoing studies. We have not even published a paper, but we actually submitted an abstract last year to ASCO.
Looking forwards, how do you like to see these results being incorporated into, say, standard care, or are there any upcoming conferences that we might find you at with more results soon?
Yes, our plan is to get the primary outcome out as soon as possible, and then currently we are collaborating with all our colleagues from all over the world to help us to analyze the tons of the data accumulated from this trial.